Okay, I think we'll go ahead and get started. We have 39 people with us so far. And good morning, everybody. I am Jennifer Thornton. I'm the Executive Director of the AT Children's Project. I'm sorry Brad Marcus will not be joining us today. He has a medical issue in the family, so he won't be here. So you are stuck with me as interviewer today. And I just really want to thank Dr. Howard Lederman, Director of the AT Clinical Center at Johns Hopkins, for joining us today. Thanks for being here, Howard.
Sure. My pleasure.
So I don't know how much has changed since our last webinar on the subject of COVID-19 and AT, but I do know that we are definitely hearing from a lot of families as they are considering sending kids and siblings back to school and activities, and as parents are having to start to go back to the office. Several AT parents are teachers and having to go back to schools. So we just thought it would be a great time to touch base with you and talk about the latest recommendations. So as parents are making these considerations and looking at what decisions to make for kids and family members, is there anything new about making the decision to return to school and activities?
So I think we largely are in the same place that we have been for the last two webinars. So first of all, there's very little data about AT or about COVID-19 in any AT patients. We'll talk about later. There's one case, but certainly not any significant experience. I think the issues still revolve around how much COVID is in the community, and then specific issues about a child. So just say that somebody has AT, I don't think necessarily means that they're at some extreme risk and they have to be kept in a bubble at home and can never go out. I think if you have AT and you have a history of lots of lung infections and you have chronic lung disease, or you are in the middle of cancer chemotherapy or in some other way debilitated above and beyond what would be kind of the norm, that puts you in a high risk group. But I don't think that everybody who has AT is necessarily or should be considered in some ultra high risk group.
So we have those with a history of lung infection, those who might be in the middle of cancer treatment. Is there a greater laundry list of those AT kids who could be considered at higher risk?
Well, I think that the older patients who have difficulty clearing secretions,
meaning difficulty coughing? Yeah,
difficulty coughing, who may have a history of aspiration, somebody who's on CPAP at night because their oxygen levels drop down. So I think that's another group that I would be concerned about. I'd be concerned about any respiratory tract infection in that group. So I think that's going to include some, but not all of our older AT people. Some of them are older without those kinds of disabilities.
So if you had like a younger one who, for example, has a G-tube because of some aspiration when having food or liquid, would you consider the fact that they had enough aspiration to need a G-tube to be enough of a reason to be considered at higher risk?
Probably not.
Okay.
Okay, so I think if there was an 8 or a 10 or a 12-year-old who got a G-tube, either because they were not able to eat enough to kind of keep up with their needs, or because some of what they were drinking was going down the wrong way, then for the most part, getting that G-tube in should solve that problem. And I don't think we have very many people that have chronic lung disease from aspiration at the age of 8 or 10 or 12, although some of them may have a G-tube.
Okay, great. So for those kids, does that mean for the kids who are at higher risk, or the people with AT who are at higher risk, what about the parents returning to work? How significant is that issue?
Okay, so I think there are a number of issues, and they really have to do with what the parents' work environment is. So most people who are working in offices these days are if they're going into work, are usually going into work with reduced numbers of people, or they are in individual offices where there's limited contact. And so I think for the most part, that should be a pretty safe environment. I think, ideally, in an office environment, everybody is wearing a mask during the day. I think if you're in an office environment where everybody is not wearing a mask during the day, that probably as an AT parent, getting one of those plastic face shields that would go over your mask would provide a little bit extra protection that would, I think, be sufficient even if somebody else in that office is not wearing a mask. Again, I think, social distancing of 6 to 8 feet is really critical. And if you stay that far apart, for the most part, you should be okay. So I think even if somebody is in the office without a mask, I think just a regular mask, that doesn't have to be an N95, but just something like what I have here, plus a plastic face shield should be more than enough extra protection. And then remembering that that hand washing is really critical. So the two ways that COVID or any respiratory virus gets spread is number one, people cough or sneeze and things get in the air. And for COVID, there does seem to be this airborne transmission. The other possibility is that somebody coughs or sneezes or gets their hands somewhere on their face and they get COVID-19 virus on them, and then they put their hand on a doorknob and you're the next one to touch a doorknob. So I think if you're in any kind of a communal kind of office, or even like my floor in a hospital, I have my own office, but there's a communal kitchen area and there's a bathroom that everybody shares. So in those kinds of circumstances, the doorknob is probably the biggest danger. So you can go into the bathroom or into the kitchen, you can wash your hands, you can prepare your food, and if you're not careful on your way out, if you touch the doorknob, you have the possibility that you get contaminated with whatever somebody else was sloppy about. So the two ways to handle that, one is you get a paper towel or a Kleenex or something like that, and you just use that to handle the knob on your way out. Or you handle that knob with your right hand, and you know that your right hand is potentially contaminated. And when you get back to your workspace, you squirt some Purell on it. Okay, and then you solve the problem.
I think those are both great suggestions. When I go into the office, I definitely take a stash of paper towels with me to use to press the elevator buttons and to open doors, and just kind of make sure that I don't touch any handle and then throw the paper towel out.
Yeah. There's certainly no reason that people should be wearing gowns or gloves if they go to work. And there's no reason we have to have people come home and strip in the garage and then run naked through the house to get to a shower. We don't need to have any streaking either inside or outside the house.
Thank God for that. That does bring me to that question, though, for sure. So the recommendation before was when you do get home from work or school, to just make sure you really thoroughly wash your hands when you do get home. Is that still the recommendation? How do you feel about shoes? Should shoes stay outside? Should you, even though you don't have to streak across the house, should you still get showered and change your clothes? What's the best recommendation?
Yeah, so I think for most people in an office, there's really no reason to change clothes and shower. Now, again, that depends on what you do. So, if you're working as a nurse, then I think your shirt can be a potential problem. If you are, if you're working in a meatpacking plant or something like that, where you've got a lot of people that are close together, and there's a lot of potential physical contact with other coworkers, that may be another one of those kind of special circumstances. Or maybe if you've got an infant, and you're going to hold an infant, and they tend to rub their face in your shirt, that might be a reason that you think about changing your shirt. I can't imagine that, with very few exceptions, and I'll bring up a meatpacking plant, that would be one of the few really high risk, close contact situations where we know there's a lot of problem, and that's a circumstance where probably people should change their clothes and shower. I think another one of those might be working in actually with direct patient care in a nursing home. Okay, where you're really, really close and you're maybe touching people.
All right, that makes a lot of sense.
Okay, possibly a preschool teacher would be in the same situation, but I think somebody who's teaching second graders is not going to have them all, physically over them.
Right. So if you're in close contact with other people all day, super close contact, and in a caregiving role, whether it's little kids or daycare, then you probably should be more concerned and remove your clothes when you get home. Okay, that makes a lot of sense.
When we think about the kind of contact, even through the air, that's a problem. If you walk into Walgreens, and even if you didn't have a mask and the cashier didn't have a mask, and you found out the next day that the cashier had COVID, you're in front of that cashier for probably a minute or two, and you're probably well out of the 6-foot boundary, and that's probably not a risk. The risk is if you spend 15 minutes or more in close contact with somebody who is incubating COVID, they may not know that they have it, and they may be breathing on you. So I think those are the kind of general common sense guidelines I would use.
So no going to bars.
Absolutely no going to bars.
No bars.
I really think people shouldn't be going to bars, and they shouldn't be going to restaurants. And I think, if you want restaurant food, you should order it for carry out. You should get it, bring it home, and eat it. The issue with restaurants is even when they have kind of dispersed dining, is that when you're actually sitting and eating, you can't eat with a mask on. And I think people naturally in restaurants get into animated conversation, and it's that kind of animated conversation that can lead to air particles, saliva that may have germs kind of getting airborne and going a little bit farther than maybe the 6-foot distance. And you have the servers that are coming around from table to table to table. So I think those are places I would avoid. Going into Costco or some other grocery store, I don't think has the same risk, because you're wearing a mask, and I would think everybody else in the store is wearing a mask, and you're not in close physical contact with anybody else for any sustained period of time.
I don't know about in your area, but when I drive past restaurants and people are eating either indoors or outside, no one's wearing their mask. None of the patrons are wearing their masks, not just when they're eating, but when they're talking to waiters, they're not wearing them. When they're paying the bill, when they're doing non-eating activities, no one's wearing their masks. And that goes for everyone in the household, right? Everyone who's living in a house with someone who has AT should avoid eating at restaurants, because that is a big place of increased risk.
Right. I think those are when the restaurants and the bars opened, or we allowed large groups of people to congregate, close together, I think that's when we started to have problems.
Yeah. What are your thoughts about kids who receive typically, if either the school district is closed or the parents decide not to send the kids to school, but they usually receive OT, PT, or speech at school? Do you think they should be receiving that instead virtually? Is that not really worthwhile and they shouldn't bother, or should they make an effort to have it in person during this time?
So I think that depends a lot on the therapy and what the therapy is doing. So I would bet that a lot of speech therapy could be done just as well by video as in person. In fact, it may be able to be done a little bit better by video, because if you're doing speech therapy by video, both the speech therapist and the person getting the therapy neither of them have to wear masks, and you can actually see the movement of the mouth. If you have speech therapy in person and both people are wearing masks, I'm not sure how effective it's going to be, actually. So I think the speech therapy for sure could be virtual. I would bet that a lot of the physical therapy and occupational therapy could be as well. The issue is whether the therapy is actually it's teaching you how to do something, or it's actually you doing it. So it could be that you could have a 10-minute session with a parent at which time the therapist teaches a parent whatever stretching exercise, let's say, they think is going to be important. And then the rest of that visit could be, or subsequent visits could be telemedicine, where the therapist is watching the parent do the therapy and critiquing and telling them, do this more or less or make this change. It may be very difficult to start some new therapy without some hands-on time. Right. Okay. So I think if you have, there's some specific new need. I don't know, somebody had a broken leg and they were in a cast for 6 weeks and they really need therapy in order to restore strength to the leg. I would think that going into that physical therapist for a visit would make good sense. And you and the physical therapist wear masks. I mean, I'm 100% confident that all the professionals that are working in healthcare know how to take care of themselves and they know how to keep the office clean. And so I think that would be a very good reason to go into an office. And I wouldn't be concerned about that. If you've got a child who is, or an adult with AT that you think is particularly vulnerable, let's say they've got bad lung disease, then I would make an appointment with a therapist and see if you could be the first patient that comes in the morning.
That's a great idea.
Okay. If the office opens at 8, see if they would make an exception for a one-time visit and you could come in at 7:30 so that everything is clean and nobody else is there. You get whatever you need done and then you leave. And I think most offices would be pretty sympathetic to that request.
Okay. However, we're getting some questions just to clarify about kids in school and masks and no masks. So one of the examples is if there's a 5-year-old without particular lung issues who has AT, they're in a hot spot and the school is not requiring masks or social distancing in the classrooms. They're just flat out opening. They want to know if they should send their kids to school or not.
So personally, if I was living in a hot spot and kids were going to school without masks, I would not send my kids to that environment.
Okay.
I think that's just asking, that's silly.
Right.
So, I really think that people should be wearing masks. And I don't think a school is different than an office. I think, I've got a 7-year-old grandson and he wears a mask. I think he, at this point, thinks it's like he's a cowboy with a bandana. I mean, I think the same way that the cowboys, at least on TV, always rode around in the West where it was a lot of dust wearing bandanas all the time. I think my 7-year-old grandson runs around inside, outside, wearing a mask. Sometimes you'd have to say you don't need to wear the mask now because he forgets it's even on. So,
so in any environment where they're not requiring masks for kids, it's not going to be a good idea for in-person school. But if the parent feels comfortable with the social distancing and the mask wearing at the school, and the child does not have significant risks such as current chemotherapy or lung issues, then that's a different story.
Right, and I think that would be okay even in an area that's a hot spot.
Right. Okay. We're getting a question, if someone has IgG or IgA deficiency, are they at particular risk?
So I have not seen anything to suggest that IgA deficiency is a risk for any respiratory tract virus. So people with IgA deficiency don't have more severe influenza, I've not seen any reports of IgA deficiency being a risk factor for bad outcomes or hospitalizations with COVID. Okay, IgG deficiency and being on gamma globulin, I think is not so clear. So if I use the flu as an analogy, I have probably 600 patients who have IgG deficiencies and are on gamma globulin, so they don't make antibody. And we give them gamma globulin, and for the most part, the gamma globulin protects them from the flu. But we probably have 20 or 30 cases a year of people who get the flu. And knock on wood, we have never had a really, really bad case of flu that was over and above what's I would expect. So, you know, if I have a 70-year-old with really bad COPD because they smoked for 50 years and they get the flu, they probably will come in the hospital. But I don't think that we're not seeing anything worse because of the IgG deficiency. There's lots of other parts of the immune system that fight viruses. And once you're infected, I think that antibody is probably not very important in getting over the infection. Now, if you can't make antibody and you're on gamma globulin, the one thing to say is that you can get an infection with COVID or anything else and recover from it, and you won't have antibody to protect you from the next infection. So that's one thing that would be different, that if you are on gamma globulin and you get COVID, I would not be confident that you would get over it and then have any immunity to a second exposure.
Okay. We're getting some questions about, we have this actually to talk about as well, but in terms of routine medical visits and dental visits, things like a routine dental cleaning, should, both for people with AT and also for everyone who lives in the household, should those be on hold for now, or should people continue to go to routine doctor and dental visits? Obviously, if you have an emergency, you need to go. But in those cases, would you put off cleanings for now?
Well, I think I might put off cleanings, but so for people that go in twice a year to the dentist, I might reduce that to once a year. But I don't want to start creating bigger problems that could be picked up just with a routine exam. I think everybody with AT needs to have a physical exam once a year, and a telemedicine exam is not a physical exam. So I would not eliminate that.
Okay. So if a doctor recommends you go see a specialist, or if you have routine visits once a year, you need to go ahead and keep up with those. Yeah.
You know, again, I think people working in healthcare have had plenty of time to figure out how to do these visits safely. And the things I would be nervous about would be sitting in a crowded waiting room. I don't think anybody has crowded waiting rooms anymore. They've figured out ways of staggering appointments, of having decreased number of people. Sometimes you may have to sit in the car until there's a room that's available, and then you get a phone call. You know, you get called on your cell phone that now's the time to come in.
I think that's great.
Okay. And again, I think, you know, if depending on the circumstance, if you've got a child that's at more risk than just say they have AT plus something else that puts them at a higher risk, that it's perfectly reasonable to ask for the first appointment of the day, or the first appointment after lunch when, you know, everybody has kind of gotten things cleaned up.
Okay, that's a good compromise. We're getting one more question about masks in school. The scenario is you have a sibling where there are mask requirements at school, but there's a very high risk AT patient at home.
Yeah, I think, you know, again, it depends a little bit on the age of the child. But if there's a mask requirement, then I think that that's probably fine. You know, kids tend to get into more contact with other kids. So if you've got one of those children that's kind of, very huggy, touchy, or you've got a young child, that might be one of those cases where when that child comes home, they really ought to change clothes and maybe take a shower.
Okay. So, and it's probably going to be impossible to predict every different scenario. So it's going to depend a lot on how comfortable parents feel about the situation, how comfortable they feel, if they can observe a classroom or two and see what's happening, if people are really keeping their masks on. But either way, if you do have concerns and someone high risk at home, it couldn't hurt to get home, shower, change your clothes before you come into contact with someone with AT in the house. That makes perfect sense.
Yeah, I think that's fine, but I don't want to say that as a routine.
Right.
That a parent or a sibling who is going to an office or goes out to the grocery store needs to come in, like I said, and strip and streak
Right.
until they get into the shower. I just don't think. I think that's over and above.
Right. The parents are going to have to take a look and see how much risk they think their child's at, plus what the situation is that the siblings are up to at school, and make a determination from there.
Right. And we're willing to do our best if people want to send us. I think they probably shouldn't plan to do this by phone, but if you want to send email messages, I'll do my best to try to keep up with them.
Okay. Thank you. I sure think that everyone will appreciate that. What are your thoughts about AT patients flying to participate in clinical trials? I know that the Ariadne study is back up and running. There's something for people 18 and over at UCLA, a nutraceutical study that has commenced. What are your thoughts about people getting on planes for such things?
So I think airplanes are probably pretty safe.
Okay.
So the air is filtered. It goes through a HEPA filter, and I'm not so concerned about transmission of germs kind of through the air. I would say that no airline is going to let anybody onto an airplane who's sneezing or coughing or seems ill. I mean, they're just not going to take that chance. I don't know whether the airlines are screening people with temperature probes, but I would bet that they are. And I think if you can, I would try to book seats on an airline that's leaving a middle seat open so that you're not right on top of somebody else. So if that's possible, I think that that would help as well.
Great.
Certainly for a relatively short trip, 2 hours, 3 hours, I think your biggest risk in the airplane is the bathroom, and it's the handle more than anything else. And you just have to be really careful that you wipe your hands when you get out of the bathroom, that you kind of, either with Purell or some Clorox wipe or something like that, that you wipe off the area around your seat, and that you wear a mask and you keep your hands away from your face. I also would say that somebody on an airplane, I think, ought to be wearing a mask plus a face shield. Okay, so those are, I don't know, they're probably $5 or $10. And it doesn't have to be anything that's super sturdy. But I think if you're going to be in an airplane, you're potentially, next to somebody for a period of time. And I think the face shield over the mask is probably a pretty reasonable extra piece of protection.
I think that's a great idea. And I think it helps protect the eyes too, right? Because it's not just the nose and mouth. You have to worry about respiratory droplets getting in your eyes.
Well, it protects the eyes. The other thing it does is it protects the mask. So
you end up with a dirty mask.
Right.
Yeah.
Right.
Which
so
you touch when you're fussing with it, and the next thing you know, you're rubbing your eyes.
Right.
And, yeah.
Right.
All right. That makes sense. Let's talk a little bit about antibody testing. So if there's someone with AT or a parent who thinks that they might have had COVID, does it make sense to have antibody testing? Would you feel more protected after that? Or is there any reason to have the testing to see whether or not you've had it already?
All right. So the first issue about the testing is that no matter what you're doing, whether you're doing a nasal swab looking for virus or you're doing an antibody test, every one of those tests has potential error. So the nasal swabs, I think, are very unlikely to turn positive unless you've actually been infected with SARS-CoV-2 and have that virus. You may get a negative depending on when you do the swab. So if you were infected 2 weeks ago, doing a swab 2 weeks after the illness is not going to tell you whether you had it. It's really only going to be useful when you're actually, maybe for a day or two before you're sick, and then when you actually have symptoms. And if people are careless about the way they get the nasal swab, you can get a negative sample or negative test because you don't get a good sample. So but I think those tests are not likely to be negative unless you get them after the fact. But you can't do a nasal swab and ask, did I have this infection a month ago? Okay. The antibody tests in the same way are generally not useful until 3 or 4 weeks after the onset of symptoms. So it takes a while to make antibody. Most people have recovered before they make much antibody, which gets to the first point I made, which is if you're antibody deficient, it probably is not going to affect how you do with this virus. So if I was exposed on July 1st and on July 8th I started, maybe I had very mild symptoms, but I had a little bit of a cough or a low-grade fever, and I get tested and I actually was positive, I would not do an antibody test until the soonest would be the very last week of July and probably the first week of August, because you need to wait 3 or 4 weeks to get the test. We also don't know how long that antibody lasts. So if somebody thought that they had this in February and it was never confirmed and they did a test now, they may or may not have had it in February. I don't know how long, we don't know in general how long those antibody tests remain positive. And the antibody tests are kind of problematic right now because many of them are designed not to be so careful about whether a specific person had COVID-19 as much as they are to screen a population. So if you have an error rate of 10% or 15% in a whole population, it might not make a big difference in terms of an epidemiologic study, but it could make a big difference for the individual patient. So you have to really talk to your doctor about exactly what the antibody test is. And sometimes you get a positive test and it's because you were infected with a related virus and not actually with this one.
So if there's no real way to know if you've had it or not.
Well, again, there are.
You end up with a positive antibody test and it doesn't really tell you too much.
Well, you just have to ask the doctor.
Okay.
If they know much about the test that's being done.
Okay.
Okay, they have to really order specific kinds of tests and they need to know exactly what that result means. And if they don't know that, they should be able to call and find somebody who can help them. Okay. Now, if let's say a parent thought they had COVID-19, they got tested and they were antibody positive, I would think that would provide some degree of comfort that it's less likely for that parent to get infected again. Okay. But we don't know how long the antibody lasts. We don't know how long that protection will last. So I don't think I would make any change in my personal practice if I knew that I was antibody positive. In other words, if I had somebody high risk at home, or well, regardless, I wouldn't go outside without a mask. Okay, even if I was antibody positive.
That's a really important point. So if it's not going to change what it is you do on a daily basis, there may not, and we don't know too much about it anyway in terms of how long it's going to be protective. Right. Having the antibody, there might not be a lot of reason to have it.
Yeah, I mean, the biggest reason for doing those antibody tests is for people that want to know if they did or didn't have it. but I don't think it ought to change behavior. And if you had it and you recovered and you have antibody, I think it's just bad for the general population for people to be running around without masks and hugging, kissing, and whatever. Because I don't know whether somebody's doing that because they've got a lot of antibody, or they're doing it because they're being irresponsible.
Right. Howard, we do know of, just to change subjects, we do know of one child with AT who has been diagnosed with as being COVID positive. I don't know how much you can say about it with privacy laws and everything, but did you want to mention what you do know?
Yeah, so this is a relatively young child who has difficulty making antibody and is on gamma globulin. And the child was diagnosed because his mother ended up getting a diagnosis. And the only reason the diagnosis was made is because of the mother's diagnosis, they started swabbing other family members. But the child with AT has had absolutely no symptoms. So again, on the basis of a single case on the planet, because he's the only one that I know of, I would not say that that means that AT kids are not going to have problems.
Right.
Okay, but that's just an indication that just because you have AT doesn't mean that if you get exposed to this, you're going to just crumple up and end up in an intensive care unit.
Right. So while we can't make a lot of assumptions because of it, it sure is good news.
Yeah, absolutely.
That this one child is fine. It is great news. Are there any supplements or medications that can be helpful to reduce the risk of becoming sick, like zinc or hydroxychloroquine or anything along those lines? We do get a few parents asking about it. So
yeah. So I don't think that there's any solid data that suggests that any drug is going to be helpful for prophylaxis.
Can they be harmful?
Well, I don't think zinc is going to be harmful in kind of the usual recommended doses. I don't think it probably works, but I don't think there's any harm to taking zinc. Hydroxychloroquine for most people does not cause any serious harm, but it does make a significant number of people nauseous or occasionally vomiting. And so I think taking a drug that may interfere with appetite or may cause people to vomit is not particularly good. Lots of people take hydroxychloroquine and have no side effects, but I've not seen a study yet that is really convincing that says that hydroxychloroquine is helpful.
Okay.
Okay, so you have to just be very careful about what the evidence is. So there's, I think, good evidence in good trials that if you're really sick and in the hospital and you get hydroxychloroquine, that there's not a benefit. Okay, there's controversy about whether there might be harm, but there clearly is no benefit. There does not seem to be benefit if you are sick enough to get into a hospital, even if you're not very sick, with hydroxychloroquine. I've not yet seen a good study that says if a household member gets COVID-19, is there any benefit in starting hydroxychloroquine on family members? And there's studies like that that are ongoing, but all the studies that have been either published or just verbally talked about are studies that are not controlled and are very difficult to judge.
Okay. How about melatonin? Have you heard anything about melatonin being helpful?
I haven't heard anything about melatonin.
All right. Talk to me about plasma therapy. I know that's something that we have talked about, what it is and whether or not you know of anyone with AT who's had it, and if that's still an option in case someone with AT is exposed.
Well, so I think there are a number of drugs and a number of approaches now to treating people with COVID-19 or treating people who are at high risk, who have a COVID-19 exposure, where I think we have accumulating data. So there is a very large, right now just observational trial using convalescent plasma for people who were either exposed or were early on in the disease. And that's been coordinated through the Mayo Clinic. It's just an observational study, so it's not the really rigorous kind of study that we would like. It's very clear that convalescent plasma, which is getting basically the liquid part of the blood from somebody who's recovered and has a high amount of antibody. So convalescent plasma in those settings has certainly been safe. And there is what I would consider still observational anecdotal data that it is helpful. Now, there's lots and lots of other circumstances in which we give antibodies to people at the time of exposure, and it has a helpful effect. So you can use that for somebody exposed to measles, for somebody who was bitten by a rabid dog before they develop rabies. There's lots and lots of circumstances in which giving antibody early on at the time of exposure before illness is probably helpful. And so given the fact that that's safe, I would say that anybody with AT who fits into a high-risk category ought to find out if they could get some convalescent plasma. I'm not sure that every AT patient needs that, but an AT patient who's on gamma globulin, an AT patient with chronic lung disease, an AT patient who has really severe malnutrition or difficulty coughing or chronic lung disease, I think they all would be eligible for convalescent plasma. And most communities have somebody who has a convalescent plasma study that's open.
Okay, great.
If anybody with AT was got COVID and was sick enough to get into a hospital, then I would suggest that they would get remdesivir at that point. I don't think that means, again, every AT patient needs to get remdesivir with the first cough. But I think if you're sick enough to get to a hospital, that I would definitely use remdesivir, and probably think about using a low dose of steroid as well.
You mean like if you end up inpatient at the hospital?
You end up inpatient as a hospital, not as an outpatient.
Right. So
Okay.
if you end up inpatient, remdesivir, and the second thing you said? Steroid.
Steroids, but in small doses, not huge doses.
Low dose steroid.
Yep.
All right. Great.
And I think there's more and more information coming out about other drugs all the time, and I think we are getting better and better at treating this disease. So
Right.
one of the points I like to make is we didn't have a huge surge, but we had a surge in cases in Maryland. So we went from about 400 new cases a day to 1,000 or 1,100. But that was not accompanied by anywhere near that kind of volume of hospitalizations. So the hospitalizations only went up a little smidge. And among those hospitalized, the number that have needed to get into intensive care units has actually continued to go down, even with the surge of cases in the community.
That's great.
And that reflects the fact that we are doing a much better job of treating people, no matter what their condition is, when they get sick.
Okay. That's all good news. How about vaccines? Where do you see us at right now with vaccines? And do you think they'll be safe and effective for people with AT?
Well, I'm pretty confident we're going to have some vaccine by the end of the year. Exactly when it's going to become available, I don't know. There are 6 different vaccines, as far as I know, that are whose development is being supported by the government, and supported not only just to get trials done, but actually to have manufacturers produce as many as 100 million doses of vaccine. So we could probably end up with, by early next year, enough doses of not each vaccine, but cumulative doses to probably get everybody immunized. Now, it may be that some of those are not going to work well, or some of those are going to have side effects, and we're not going to have all of them available. But would not surprise me if by early 2021 we had 200 million doses of some combination of vaccines, which, at least in a general healthy population, led to the production of antibody. So I think the kids with AT who are not on gamma globulin should, now I'm going to put a caution here.
Okay.
Right now, I would think, unless there's something that I see in terms of safety, that kids with AT should probably be considered high risk to the point of getting in the front of the line to get a vaccine. Again, without a specific vaccine candidate, I don't want to make any kind of specific recommendation, but I would just say that in general, I would expect that these are going to be safe for people with AT. I don't know whether they'll be as effective, but the issues for people with AT, like any other high-risk individual, is if there's lots less virus circulating, a person, even if they can't respond to the vaccine, is going to be protected because there's less virus in the community. So I would say as a priority, not only do you get the child with AT immunized, but as soon as it's released for the general public, that everybody in the household gets immunized.
Right. Similar to your recommendation every year for flu shots, which actually brings us to the flu shot question. I know that every year you like to wait to make the recommendation for everyone to get their flu shots until a certain month or until you know that the shots are actually directed toward that year's strain of flu. So what are going to be your recommendations this year for everyone to get their flu shot?
Well, the reason we hold off sometimes on the flu shot is that it doesn't always, the protection doesn't always last for the whole season. So I think actually that lots of pharmacies, at least around here, already have flu vaccine available. There is no flu anywhere in the United States that I'm aware of right now. And I think getting a flu shot in August is not going to be a great idea because the flu season could easily last till March or April. So we'll kind of track the flu as it gets into the United States. Usually I recommend it more like end of September or sometime into October. But I think we just have to see. I think the flu transmission might be much more limited this year than most years because so many people are wearing masks and so many people are careful about washing their hands. So it would not surprise me if we didn't get much flu in September, October, and the flu season didn't come until later on.
Right.
But I think everybody ought to get a flu vaccine. And again, I think you have to just figure out a safe place to get it. So I probably wouldn't want to have anybody waiting in some long line in a gym where there are 150 people waiting to get vaccine. On the other hand, you know, going into a doctor's office early in the morning, being at Walgreens, and I don't want to say that you can't go to any other drugstore. I don't know. I shouldn't just say Walgreens, but going to, you know, to some other not doctor office site where you get a flu vaccine.
You're saying that is okay to go to a drugstore, supermarket?
I think it would be fine to go to a drugstore or a supermarket, and I can't imagine you're going to get them to open early. But I will bet that most of those stores don't have a lot of customers waiting in line to get into, you know, the drugstore the second that it opens. So that's what I would suggest is that, you know, if the store opens at 9, that you're parked in front of it at 10 to 9, and the minute they unlock the door, you go in there and get the shot.
And like you do every year, you'll let us know when it's time to send out the email to all the families.
Right.
So I want everyone to know that we'll be sure to send out an email when you say it's time to go get your shots.
Yeah, I just think it's too early right now. I would not get a flu shot right now.
Okay, so it'll probably be closer to end of September, early October, somewhere around there. But
that's my bet. But
okay,
stay tuned because we'll send it out.
Okay, great. Are there any other thoughts you have before we wrap up?
I would just say that I think we're in a, even though the number of cases is going up, the number of hospitalizations, the number of ICU admissions is really going down for the whole country. We're not seeing the kind of, mass catastrophe that we had when this first hit in New York City. So I think we are much, much better able to manage patients who get infected with SARS-CoV-2. We do a much better job of taking care of them if they're sick enough that they need to be in the hospital. And most of the time, they don't need to get into an intensive care unit at all. And so I'm already feeling much more confident about our ability to manage this disease in general. Great.
And that's just going to be good news for everyone and also for everyone who has AT. So that's all really good news. I definitely want to give a very big thank you to Dr. Lederman and the whole team at the AT Clinical Center, and to Jenny Wright and to everyone else who's been busy trying to manage everything during this crisis, but also over the years. And a very big thank you to all of our families, many of whom are on the line right now, who do all the fundraising that helps make it happen at Johns Hopkins. For those of you who don't know, it's all funded by the grassroots efforts of families and friends who raise the funds for the clinic. So thank you all for everything that you've been doing over the years. It's really wonderful at this time to have such experts who've seen so many people with AT and do such a fabulous job managing AT. So thank you to Dr. Lederman. Thank you to all of our fundraising families who make it happen.
And I'd second the thanks to all the fundraisers, and certainly to Jennifer and Brad and everybody at the AT Children's Project, because none of this would happen without them.
Well, thank you. We appreciate that. And if anyone has any lingering questions, please do call me, text me, email me. We'll be sure to get them to the doctors and disseminate it to everybody. And I'll let the chat go for a few more minutes and let Dr. Lederman get on about his day. And thank you so much for joining us. It's been really, really wonderful.
Okay. Like I said, I think if people have a specific question about a specific patient, that's best handled with an email to Jenny. And certainly if anybody has somebody in the family with AT who gets COVID-19, do not hesitate at all to reach out, and we'll do our best to help if any help is needed, and hopefully it won't be.
Thank you. I know everyone really appreciates that. It definitely gives everyone a feeling of comfort to know that you're there. All right.
Okay.
Thank you, everybody.